And our next speaker is Dr. Bhavik. He'll be speaking about looking beneath the retina, management of subretinal bands in PVR. Dr. Divakant, if you can join us here. Dr. Komal, you can join.
Okay, so good morning everyone, and thank you Dr. Avnish for inviting all of us here. So I'm going to start with the case. This is a 27-year-old male who had a corneal tear repair and traumatic cataract surgery done elsewhere a year ago, and he had a good vision, decent amount of vision, and he came with vision loss to us. So his vision at the time of presentation was 21/25, and the left eye was unremarkable with 20/20 vision. So in the right eye, we see a corneal scar with the peripheral anti-cyanic, cataract with multiple pitting on the IOLs, maybe multiple lasers were attempted to remove the capsule behind the IOL. And if you look at the fundus, there was a hazy view, but there was a retina detachment, and there was an irregular retinal surface with kind of tenting which was present here, right? And if you look at the B scan as well, so the B scan also showed that tenting surface which was noted. So if we compare here, clinically you could make out there was a subretinal band which was passing across the retina and close to the disc as well here. So just a short video of, so the core vitrectomy was done for this patient and ensured after the encirclage was 240 band was applied, ensured the entire peripheral vitrectomy was completed. And then if you look here, a small axis retinotomy which was made over the subretinal band using maxillary forceps. The band was removed through the drainage retinotomy itself, and the band could come in toto. Some part of the band, the extension of the band was from the inferior retina going until the nasal retina. Some part of the band remained towards the nasal retina, did not come, and then it was laser was performed and silicone oil was injected. Okay, this is post op day one picture. This is just a recent surgery, but the band was not there. There was no traction, and the patient had decent vision as well. So PVR can complicate regmental retinal detachments, and this contributes to poor visual outcome. And this basically PVR is an irregular scarring process characterized by growth of membranes on both the surface of the detached retina and also onto the vitreous. So just for people here, if you look at the grading of PVR, the updated Retina Society, grade A indicates earliest process with pigment clumping in the vitreous. Grade B indicates rolled edge of the retinal tears, and grade C indicates formation of pre-retinal or subretinal bands. So here we are dealing with the grade C PVR. So management of subretinal bands can be complex. It can be either observed or intervention might be required. So let us look at the scenarios where an intervention is required, or we can observe the patients. So observation is required, or it's indicated when a subretinal band is present in the periphery and there is no traction on the macula, okay, and the vision is maintained. Or in certain areas you have traction in the periphery and only a scleral buckle can be performed for such individuals. Whereas when you look at traction which is involving the macula, and you feel that okay, this patient needs surgery and you have to remove the band as well because it's not going to allow the retina to settle. So along with the encirclage, vitrectomy can be performed. And if you look at the approaches to remove these bands, it can be either a subretinal approach or via an axis retinotomy. Okay, so what is the best approach? So we have to assess the amount of traction and the status of the vitreous. Okay, so say for a scenario, young patient, the traction induced by the subretinal bands which is away from the macula, maybe a scleral buckle is indicated, or traction posterior and more significant, removing the band should be considered at the time of the retinal detachment repair. Subretinal bands can be removed via axis retinotomies, or you can also make larger retinectomy to allow the peeling of the membranes around, and an entire sheet of the band can be removed, or a retinectomy can be performed that excises the subretinal bands altogether, and the area of retina itself can be taken up to relieve the traction. So this is a video where we see that an axis retinotomy is made, just similar to our case. Okay. And again, this was made over the band, and through the axis retinotomy, the band is removed in toto. Right. So this allows for the retina to settle, and there is no traction which is present. So the next question arises: where to place them? Where to place your axis retinotomies? Do you place over the band itself or adjacent to the band? Right. So here it's important to understand that if you're placing it over to the band, there is a chance that you can damage the band, and the band can itself snip and it may retract. Then it's difficult to go and retrieve. If it retracts and still there is no traction, that your job is almost done. Whereas other way around is that you make a drainage axis retinomy which is adjacent to the band, and from there you can take your forceps and you can remove the band. Right. So anticipate the angle at which the forceps are going to bend, and you're going to capture or take your subretinal membrane out. The band has to be removed slowly with attention to the retinotomy, because there is a chance if you try to manipulate a lot, the retinotomy may actually increase in size. Okay. And large bands can be removed with use of a chandelier and bimanual technique as well. So just to conclude, PVR complicates regmetous retinal detachments. Subretinal membranes causing traction can lead to recurrence, and the subretinal membranes with no traction or traction away from the macula can be either observed, or a scleral buckle can be performed. And causing traction at posterior pole, vitrectomy with encerclage is the way to go ahead. Thank you so much.
Nicely explained, Dr. Bhavik. So, how often actually do you go with? Do you actually go in removing bands, subretinal bands for all your cases, or you actually have like this is a case where you decide pre-op that, or maybe on table it sometimes happens that you are trying to settle the retina where it is more extramacular. So, can you give one or two pointers on the same?
Yeah, especially say young patient post trauma, and you have a subretinal band which is traversing through the fovea. Okay, and you have an access to it which is away from the fovea, away from the arcades, and that you know that the band is also contracted, it is not going to allow the retina to settle down. So those are the cases where I'll go and remove the band. If I have peripheral band, okay, and I can manage with the buckle, I'll not do a vitrectomy for such individuals, especially post trauma dialysis. You may not go ahead with the vitrectomy, and the bands can remain there. Okay, and if it's not causing attraction, the retina can settle this.
I mean, most of the times we do tend to see if there is more tenting, during the surgical, when you start up with the vitrectomy, that is the time where you see that if the retina may not settle, there would be some subretinal, the retina is not settling. Those are the times we'll decide that these are the bands which needs to be removed. As you said, not all bands should be removed. One more thing was when you are actually pulling out the bands, so do you use any specific technique like the spaghetti technique, or
Yes.
how do you go about looking at the band that this is how you would want to, if you can give some
Yeah.
feedback on that?
So some bands are quite tougher. Okay, and you tend to pull it, and you realize that there is a stronger adhesion. That is where itself you can actually have the spaghetti roll technique, and they may come up into your forceps.
So that was very nice, Bhavik. Uh, I guess it's important to note the point of discussion here is that not all subretinal bands might need removal. It's basically if there's just a focal traction or a focal star fold which is not hampering your retina reattachment, then you might just leave it. I guess the more important ones are the circumferential ones, which are more difficult to remove. And for those kind of bands, either the retinotomy would probably be adjacent and not on the band, because
True.
just by breaking the band, you're not relieving all traction. So the kind of band and the direction in which the band is going, to assess that intraoperatively is quite important.
Thank you.
Dr. Bhavik, nice presentation. How about approaching it from the outside through a sclerotomy, more posteriorly located sclerotomy?
I have never tried that. I have no experience with that.
We tried in one case with extensive band. It worked really well. Dr. Naresh Babu had also shown in one of his presentations.
But Dr. Devakant, in those cases, I mean, what actually happens when you're going from outside? Uh, there is sudden SRF which kind of comes out. So when, I mean, those are the times in the retina, there is a very high chance that you may actually cause more damage to the retina,
You
right?
just need to use a walled cannula. And so, yeah. A more posteriorly located sclerotomy and using a walled cannula so that there's no gush of fluid.
Thank you, Dr.